will introduce our presenter, Jordan Bontrager from the University of Rochester Medical Center.
Thanks for the introduction, Erin, and thank you to everybody here today. And a huge thank you to MDA for asking me to speak on this topic. As you all know, over the last 5 to 10 years, genetic testing has become much more commonplace in the neuromuscular disease realm. And therefore, we need to feel comfortable with genetic test selection, ordering genetic tests, and interpreting results, all of which hopefully I'll be able to touch upon briefly today. So our program objectives are to first kind of dive into the importance of genetic testing in neuromuscular disease, recognize commonly used genetic tests and genetic test methodologies, become familiar as familiar as possible with ordering and interpreting panel tests, and then find some additional tools, resources, sponsored programs, etc., that might help you in your day-to-day practice. This is our agenda. So as you all know, neuromuscular disorders consist of a genetically and phenotypically heterogeneous group of diseases. So caused by many different genes, many of which overlap in terms of phenotype. They can disrupt the skeletal muscle, the neuromuscular junction, the peripheral nerves, and are fairly common. So neuromuscular diseases as a whole affect about 1 in 1,000 individuals worldwide, whereas hereditary or genetic forms of neuromuscular diseases are more around 1 in 2,500 is the estimate. The inheritance patterns for neuromuscular diseases vary based on the disease of interest, the gene at hand, or even the mutation. So even within the same gene, a specific mutation type or location of a specific mutation or pathogenic variant, which I'm going to use interchangeably, just know that those two terms are the same. It could be that a different pathogenic variant could be associated with recessive disease within a gene, whereas another pathogenic variant might cause dominant disease. So it gets very tricky in terms of inheritance patterns, but they are grouped into kind of these 4 main categories. The first being autosomal dominant disease, which means that a person has 2 copies of a gene, and having 1 copy of that gene harboring a mutation is sufficient to cause disease. Typically, in these types of families, there's multi-generational inheritance, so you'll see affected individuals in each generation. That's not always the case. There is always going to be the first person in the family to harbor a mutation in a gene. There's also decreased penetrance for some of these genes, so there might be people that have a mutation that don't exhibit any symptoms. So again, it gets a little bit tricky there, but dominant disease really just means that 1 mutation is sufficient to cause disease symptoms or increase risk for a disease. Some examples of this are myotonic dystrophy, oculopharyngeal muscular dystrophy, or Charcot-Marie-Tooth type 1A. Recessive inheritance means that having only 1 copy of the gene harboring a mutation is not sufficient to cause disease. You really need both copies of that gene to have a mutation in order to have disease symptoms. Typically, how this occurs is that mom and dad are both carriers of a mutation in a particular gene. When they go to have a child, they have a 25% risk of both having passed on that mutation. And therefore, we see usually just 1 person in a family that has disease symptoms, maybe some siblings, but we aren't typically seeing generation to generation transmission. Some examples of this are spinal muscular atrophy, Pompe disease, sarcoglycanopathies. X-linked inheritance occurs when a gene is located on the X chromosome, and the main characteristic of this is that females are much less severely affected than males. So males are more severely affected than females. And that's because males only have 1 copy of these genes and therefore don't have another copy of that gene to kind of compensate for the function. Therefore, when you see X-linked disease inheritance, you're oftentimes going to see either asymptomatic females or very mildly affected females with more severely affected males within a family. And typically it's kind of going through that maternal lineage because of that. So that, again, this is everything that I say today. There's some exception to that. So I will caveat that here because there are X-linked disorders that can affect females very significantly as well. But some examples of X-linked disorders are dystrophinopathies or Charcot-Marie-Tooth type 1X. And then maternal inheritance is really mostly talked about in terms of mitochondrial disease, in particular mitochondrial disease caused by mitochondrial DNA mutations. So a person inherits all of their mitochondria from mom, and so if there is a mutation in the mitochondrial DNA, that's maternally inherited and is coming through the maternal lineage. So how do we figure out which patients are appropriate to test for genetic causes of neuromuscular disease? First is making sure that we're taking a detailed history. So a birth and a prenatal history, as well as a developmental history, and kind of get a good sense of how this disease has progressed, when symptoms arose, and how many different systems are involved as well. So some red flags for hereditary or genetic disease are long-standing or slowly progressive symptoms, multi-system disease. Obviously, if the rest of the workup for acquired causes of overlapping disorders has been normal, that gives us some indication that there could be a hereditary process, early onset of disease symptoms, and then similar symptoms in other family members. So if there's a positive family history that looks very similar to your patient, that's a huge red flag that there could be a genetic component. The second piece is really localizing the disease process. So is this a disease of the muscle, the motor neurons, the peripheral nerves? That's going to help you guide your test choice and kind of make the best decision in terms of where to test and the type of test to order. Genetic testing broadly is the analysis of a patient's DNA to look for abnormalities that cause or predispose an individual to disease. The tests vary based on methodology, with sequencing tests looking at kind of the individual spelling of these genes to look for pathogenic variants within a patient's DNA that can lead to disease. So genetic sequencing tests are really kind of looking for smaller sequencing errors or spelling errors within a gene that can lead to disease. Chromosomal genetic tests are looking broadly at whole chromosomes or long lengths of DNA to look for genetic changes, big missing or extra chunks of DNA, rearrangements, etc., that can cause a genetic condition. And then I put biochemical testing on here, although it's not necessarily genetic testing, it's very much genetic testing adjacent. This testing looks at the activity of certain enzymes or proteins, which when they're abnormal can suggest a particular genetic diagnosis. This testing can also include looking for certain biomarkers that can be elevated or decreased in particular genetic disorders to either help support a diagnosis or to monitor progression of disease. The benefits of genetic testing are manyfold. First and foremost, it can help end the diagnostic odyssey for patients who oftentimes have been bounced around to many different providers, have never really gotten a clear explanation about what's going on or what's causing their symptoms. So kind of solidifying a diagnosis for a patient, putting a name on it, which can empower patients enormously, and then kind of giving a better idea of the prognosis for that patient. It can also, for asymptomatic patients with a family history of a genetic diagnosis, give a better idea of what their risk is for developing a genetic disease or developing a disease over the course of their life. It may allow patients to avoid unnecessary or invasive tests, such as muscle or nerve biopsies, which were more routinely done in the past before genetic testing, but more and more so we're doing genetic testing first, and then if needed, going to muscle biopsy or these kind of surgical procedures. So genetic testing has allowed us to decrease the need for these invasive procedures. Diagnosis with genetic testing can allow for determining appropriate treatment. So sometimes there are targeted therapies for these genetic diseases, or you can avoid unnecessary or potentially harmful treatments. So immunosuppressives, or in the example of mitochondrial disease, making sure that you're avoiding toxic drugs for mitochondrial function that could make things worse. It could improve access to clinical trials, emerging treatments, as well as open doors for additional services for patients through their community, school, work that might otherwise not be available without a distinct diagnostic or diagnosis. The knowledge of the disease can also help aid in family planning for your patient, for other family members. It can help test at-risk family members who may need surveillance ahead of time for things that could be life-threatening, like cardiac disease, and also assess reproductive risk for the patient at hand, but also other family members. So can really guide a lot of this kind of family planning piece and also pre-symptomatic testing piece for other people in the family. There are many types of genetic tests. I'm going to talk about each of these ones on the slide in more detail, although most of our focus is going to be on next generation sequencing, given that's probably what you're ordering day to day within your own clinics. But we'll talk about single site testing, single gene testing, cytogenetic testing, as well as panel testing and exome and genome. So to start off, we'll talk a bit about single site testing. This is used in a scenario where there's a family history of genetically confirmed disease. So this is a scenario where you have a patient come to your clinic, they say, my mom has a diagnosis of X disorder, she's had genetic testing, you may be able to do single site testing. This is going to be the most sensitive testing option. So what this does is it's just looking for that familial mutation as opposed to looking at many genes at once or even looking at a full gene at once. Depending on the lab, they may look at the full gene or they might just really look at that specific location of the family member's mutation. So this is going to be most sensitive because we know we're looking at the exact spot where that mutation is. So a true negative we can really feel confident in. Versus if we don't have that test report, it could be that we're missing something due to test limitations. There's the least possibility of uncertain findings or unanticipated findings with this because, again, we know exactly what we're looking for. And then prenatal testing and pre-implantation genetic diagnostic testing, oftentimes you do need to do single site testing. So there are, again, exceptions to this, but for the most part, for prenatal or PGD, we need to do single site testing or have confirmation of a familial mutation to do the test. To do this test, you often do need confirmation of the familial mutation in the form of a family member's test report. Labs can differ on how lenient they are on that, but typically they want that. That can be difficult. So depending on the dynamics in the family, how close the patient of yours is to the original proband, it may be impossible to get that, in which case you default to another test. But if you can get it, it's best to send your patient sample to the same lab that the original family member was tested at, as they may use the proband's DNA as a positive control. Single gene testing is utilized when there's a high suspicion for a particular disorder with one known genetic cause. So some examples of when you might do single gene testing is in a kiddo with suspected Duchenne muscular dystrophy, a patient that looks like they have CMT1A, a patient with myotonic dystrophy. You may choose to just test one gene. The main thing that you need to be considering in these scenarios is the molecular mechanism of disease or mutation type. You want to make sure that the test that you're ordering is going to capture the main types of mutations that cause disease for that gene. So for diseases that are caused by sequence variants, so these small spelling changes in genes, doing testing through sequencing or next generation sequencing is typically sufficient. If the patient has a deletion or duplication, it really depends on the size of it. If it's multi-gene and quite large, you may need to do something like a microarray in order to detect it, versus if it's a multi-exon deletion or duplication, typically next generation sequencing can detect that. So again, just kind of understanding what the mutation is that you're looking for and making sure that you're using the right test to look for that mutation. Tandem repeat disorders are a whole separate can of worms. They're not going to be detected by next generation sequencing, so you do need to order a separate assay for these. Typically, these are done by either repeat prime PCR or Southern blot, though there are new technologies that are coming out to detect these. But things like myotonic dystrophy are not going to be caught via next gen. So, testing CNBP via sequencing is not going to give you the information that you want. So making sure that, again, you're thinking about the technology that you're choosing for analysis for single gene testing. I'm not going to talk a lot about cytogenetic testing because we don't often use it in neuromuscular disease. It doesn't come up all that frequently. Most of you will probably come across cases where you're either ordering or you're analyzing a microarray. So that's maybe the more important thing to be aware of is microarray analysis. All of these different cytogenetic tests are looking at, on a chromosome level, large portions of DNA to see, are there missing extra chunks, any rearrangements, whole extra chromosomes, etc. And microarray really scans these large sequences of DNA to see, is there a deletion or duplication that spans multiple genes that could be causing a disorder. These are more commonly used for pediatric, complex, syndromic type of phenotypes. It's recommended as the first tier test for patients with developmental delay, intellectual disability, autism spectrum disorder, or multiple congenital anomalies. So again, doesn't come up all that frequently, but might be something for a particularly complex case that you may need to order a chromosomal microarray. And then panel testing is most likely the type of testing that you're doing on a day-to-day basis in your clinics. This test looks at 2 or more genes at the same time and is ordered when a patient has symptoms that either don't cleanly fit into a single condition or when a particular genetic condition can be caused by many different genes. Panel size can vary significantly from as small as 2 genes for something like a spinal muscular atrophy panel to over 200 to 300 genes for a large neuromuscular panel. And they get even larger when we look kind of outside of the neuromuscular realm at things like leukodystrophies, which can be 700 plus genes, intellectual disability, which can get upwards of 1,000 genes. So these panels get kind of crazy big at some point. The genes in these panels are grouped based on phenotypes. So depending on how narrow that phenotype is, the panel will get larger and larger. So something like a non-dystrophic myotonia panel might only have 5 or 6 genes, whereas a large neuromuscular panel is going to be upwards of 300. These are run on next generation sequencing platforms, which typically include sequencing of and deletion duplication analysis of the protein coding regions of these genes, so those exonic regions, as well as a small portion of the introns, so normally plus or minus about 10 base pairs. So this is not looking in the deep intronic regions. Those variations will be missed. And they're, again, just limitations of this particular test. So choosing a lab and a genetic test can be difficult, time-consuming process. The main thing you want to start with is choosing a lab that's accredited. So making sure that the lab that you're looking at is CAP and CLIA certified. And then thinking about how long that lab has been doing testing within the neuromuscular disease space. So labs that have more experience testing patients within the neuromuscular disease realm are going to have more internal data that will help with classification of variants. So as these labs accumulate internal data, it decreases the likelihood that they're going to return a report with a whole bunch of EUSs that you're going to have to work through. They're going to have more information to either call variants benign or pathogenic and kind of make a bit more clarity in those reports. You want to make sure that you're capturing your genes of interest, of course. So if you have something that's high in your differential, make sure you look at what genes cause that and then make sure that's on your panel. Also consider that the limitations of next generation sequencing. So if you're doing a large neuromuscular panel, but you have some concern for FSHD, you're going to want to do a separate assay for FSHD because we know that the panel testing will not detect that. One of the questions I get asked often is whether we should just order the biggest test that we can. And I think that there are scenarios where ordering a bigger test is warranted for many reasons. Either a patient doesn't fit into really a phenotypic bin to kind of order a more targeted panel. And maybe that logistically, that's the best option from a financial standpoint. A sponsored panel may be best, that's bigger. But if you're able to do a smaller panel based on phenotyping and your differential diagnosis, I do recommend that because the bigger the panel gets, the more uncertain findings that you need to weed through. And that can be confusing for patients, it can be confusing for clinicians. And so it kind of opens up a can of worms that doesn't necessarily need to be opened if you're able to do a smaller panel first. Cost and logistics, I'm not going to go into. This is my first plug of the day for a genetic counselor, or genetic counseling team if you don't already have one. Genetic counselors, genetic counseling assistants all help with looking into insurance coverage, making sure that patients are aware of what their out-of-pocket cost will be, and then making sure logistically things are smooth. So what type of specimen do we need to collect? How are we going to collect that? And kind of all of those moving pieces that a genetic counselor can address within a clinic. This is just to highlight how complex the test selection process can be. So this is Genetic Testing Registry. It has not all, but most of the genetic tests available for human disease. I typed in muscular dystrophy. You can see there's over 1,700 tests that returned. So if you're starting from scratch, that's a real daunting thing. The neuromuscular disease panel I have on here just to highlight the broad nature of it, that it's including muscular dystrophies, myopathies, myasthenic syndromes. But even given that, there are significant limitations. It won't detect OPMD, FSH, myotonic dystrophy. So even when you're ordering these big panels, there are always going to be limitations, and you need to be aware of those so that if you do need to do a separate assay, that you're able to do so. All right, I'm going to put a big caveat on this slide. I wanted to put this in because I think the interpretation of genetic testing is arguably the most important part of this process, but this slide does no justice to the complexity of variant interpretation. Variant interpretation is difficult. It takes training, it takes practice, and even for people that do this every day, it's a really complex and tedious process that can be very confusing. So there are many pieces of data that need to be considered when looking at genetic test results. I highly recommend additional training or an addition of a genetic counselor to your group to help with this, as it can be quite time consuming. So again, my second plug for a genetic counselor or a genetics professional within your team that can kind of help with the nitty-gritty details and looking through the interpretation of these variants. But broadly, I think you can always ask yourself, what's the zygosity of the variant? Is it on 1 copy or 2 copies of the gene? Does the disease that the gene caused match the patient's phenotype? Does the inheritance align with the patient's family history? This gets back to the importance of getting a comprehensive family history for each patient. And then is additional testing needed to clarify? Can we do parental analysis? Is there any biochemical testing we can do? Kind of thinking through those things in terms of next steps for anything that you are suspicious of. Utility of panel testing, it's less expensive than Sanger sequencing used to be, which is huge, less expensive than Exome and Genome. There's high coverage across the genes of interest. So if there is mosaicism, so something that's not inherited, but rather came up in a somatic event, this can be found on next generation sequencing just based on how many reads there are at each location. And then there's a lower chance of finding things we aren't looking for than Exome and Genome. So that's a pro as well. The cons are that as we add more genes, there's more uncertain findings. Labs are going to return back every uncertain finding in every gene on the panel, and so this can get a little unwieldy. There is a need for in-depth interpretation, as I keep harping on. So making sure that you're prepared to do that and that you have time set aside to do so is important. And then patient comprehension can be difficult. So some patients will really cling to a VUS as a possible diagnosis when realistically it might be nothing. And so making sure that to the best of our ability, we're able to convey to patients what a VUS is, what it's not, and kind of making sure that that's fully comprehended on the back end. Whole exome and whole genome sequencing tests look at all known human disease genes with the goal of identifying a genetic cause of disease. While all of these disease genes are sequenced, the point of the test is not to report back all disease-associated variants. So this test is not built to tell you everything that you're at risk for that you might develop based on your genetic makeup. That's not the scope of the test. The test is really meant to focus in on the reason for referral. There are very complex interpretation and variant filtering and gene filtering mechanisms from a bioinformatics standpoint that help hone in on genes of interest. So just know that some patients come in thinking that this is a test that's going to tell them everything they're at risk for, and that's not what this is. However, they are big tests. The main difference between the two of them is that exome sequencing is only looking at the protein coding regions of these genes. So it's only looking at the exons versus whole genome sequencing, which is looking at the protein coding regions, the exons, non-coding regions, or the intronic regions of the DNA, and it looks at mitochondrial DNA. So it's a much bigger test. It's less uniformly covered by insurance, as you might know. So I think that as we move forward, genome will become more commonplace, but right now getting payers on board with it is a little bit difficult. But these are kind of the two broadest sequencing tests that we have available. If you leave here today with knowing one thing about exome and genome sequencing, I hope that it is that the clinical information is everything. The test is only as good as the information that's provided by the clinical team. So clinical notes, any electrodiagnostic studies that you have, muscle biopsy, anything relevant to the patient's phenotype should be provided to the laboratory. And they really need that in order for the bioinformatic pipeline to work correctly. And so if you don't provide that, A, they probably won't run the test. But B, if they do run the test, your report is going to be not all that informative. So again, making sure that you're getting all the lab, all of the documentation that they need to make sense of the results. If you can do a trio and include parents, that's great. That helps with segregation analysis. If you can include an affected sibling or something along those lines, that's also helpful to kind of parse out segregation. There is an increased likelihood of incidental findings. And because of this, an in-depth consent process is necessary. This is a complex test. Patients need to be aware of what they're signing up for. Special considerations. This is a high cost test. You need to make sure that your patient's not going to get a $10,000 bill. So again, whether it's you or whether it's somebody on your team, a genetic counselor, somebody else that's looking into the cost of testing for patients, that's crucial. Incidental findings are also a big piece of things to consider here. So if we're doing a trio, we could find non-paternity, consanguinity, both of which should be discussed with the patient prior to testing. And then there is the option to return findings in medically actionable genes, which are mostly related to hereditary cancer syndromes or cardiac disease. So again, usually not the reason the patient is there, but the lab is offering to return findings in those genes for medical management purposes. And so it's very important to talk with the patients about, do you want this information or do you not? And what are the implications of if it is positive? What would that mean for you, both in terms of how would your care change, but also what that could mean from an insurance standpoint. So from a life insurance standpoint, long-term care, disability insurance, there is a risk of discrimination based on those results. So that should always be discussed with patients as well. Again, big topic, lots to go over in that consent process. Strongly recommend involving genetics. Even just referring out to a genetics team to do this is definitely reasonable. Even though this test is very comprehensive, there are limitations. It may or may not include copy number variant analysis, particularly exome. It won't include methylation studies, so there are certain disorders that might be missed, like Prader-Willi syndrome, Angelman syndrome, some more of these kind of pediatric disorders, but if there's a methylation-based disorder, it would be missed. Exome can't detect expansions or contractions in repeat regions. Anything that's difficult to sequence, kind of these pseudogene regions, might have decreased coverage, so you want to make sure that you're checking on coverage for those if you're specifically interested in those genes. You aren't going to get expression data, and again, to harp on this again, you really need to, the test is only as good as the information you provide to them. There are scenarios where testing may be inappropriate. There are lots of talks about this, so for the sake of time, I'll kind of breeze over this. But if a patient is unstable emotionally or psychologically, unable to properly provide informed consent, testing of minors for adult onset conditions or carrier status, or prenatal testing for adult onset disorders is typically not recommended. And then thinking about the, who's the correct provider for this? Are you comfortable interpreting these results? So not ordering the test if you feel like interpreting those results is beyond what you're comfortable doing. And then obviously cost of testing. So broad overview, ordering a genetic test, you want to carefully consider your test options, discuss with the patient, ensure they want to proceed with that test, get your informed consent, obtain insurance approval if needed, get the sample, whatever that sample might be, and it might depend on the test that you're doing what the most appropriate sample type would be. You send that sample along with documentation to the lab, wait for your results, and then interpret those results. And again, that's a big piece of this, is this interpretation. If you need to call the lab, they oftentimes do have genetic counselors or clinicians that can talk to you about the results and kind of clarify anything that's unclear. So I would encourage you to utilize those resources, and then discuss with the patient and follow up with any necessary next steps. These are a couple resources I wanted to mention. The first is a place where you can go on the National Society of Genetic Counselors website to find a genetic counselor for referral if interested. And the second is a variant assessment tool that you can use in interpretation. Again, take it with a grain of salt, but you can put in a variant into this tool and put in your patient's phenotype, and it will pull up a lot of data surrounding the variant, kind of technical data as well as publications surrounding that variant. So it can be helpful if you're trying to work through interpretation of results. And then this is a list of sponsored neuromuscular disease programs. It is not comprehensive. I know I missed some. And just know that each program has specific eligibility criteria. So you need to make sure your patient fits within that eligibility criteria before you do the testing. And also a plug here that there is a data sharing component to this. So usually of the pharmaceutical company or patient advocacy group that is paying for the testing does get access to the patient's de-identified data. That depends on the program, but certainly making sure your patient is aware and comfortable with that before you proceed with testing, making sure that's part of your consent process, because some patients will opt out of testing for data security reasons. So I'm not going to go over each of these. This is for your reference in the future, but certainly reasonable to consider these programs for cost effectiveness. And I thank you all for your time. I hope we still have time for a couple questions.